Welcome. Thank you for joining today's session on Algorithms to Outcomes, the Economic Impact of AI. My name is Prem Bachu Green, and I am the Vice President of Clinical Innovation and Value at Viz AI. Viz AI is a leading AI-powered disease detection and care coordination platform, and it's used in more than 1,700 hospitals in the US and Europe. We have over 100 clinically published studies that showcase the real-world evidence of the Viz AI platform. Please visit our website at vizai.com. I'm joined today with two exceptional leaders in the space. Deborah Mullen, a PhD and Professor of Management from the University of Tennessee, and Dr. Thomas Devlin from CHI Memorial, Director of the Neuroscience Institute. We're looking to have both of them share some of their insights on the use of AI in clinical patient outcomes and how that's impacted the overall economic landscape as we look at the cost of care. Dr. Devlin, can you give us a quick overview of how you've used Viz AI across your system and to manage patients that arrive at your hospital with stroke symptoms?
Yes, very exciting topic. Thank you, Prem. We've been in the stroke game now for almost 30 years. We were the first center, the clinical center in the US to employ Viz. And as you know, Viz has rapidly spread across the United States. We've been very excited to see that. I think it's important to remember that Viz was the first artificial intelligence platform for LVO detection in the stroke world. So we have a lot of years of experience. We have at our comprehensive center, we have Viz at our comprehensive center. We have Viz in all of the hospitals that we own in the region, our referral centers. And now we have put Viz at a number of centers in our catchment area that are referring into us. Also having a lot of experience in telemedicine. I have a lot of experience as a stroke provider. Both at the comprehensive center, but also at the referral centers, where I'm currently linked to 138 hospitals on my Viz account. And it really has been very, very revolutionary. So we are tied, our stroke neurologists have it, all of our interventionists have it, our nurse practitioners have it, and we're communicating daily between all of our team and all of the outside referring teams. And it's been really a very, very amazing transition to see how much patients have benefited and how much faster stroke work care has gone since implementing Viz. It's been a very, very exciting time. Just when we lived through the era of bringing neurointervention to the field and making it standard of care, just when I thought we couldn't get more excited about anything, the AI algorithms in Viz came along, and we realized not only could we do it on the intervention side, but we could do it so much better and so much faster when time is brain. So it's been very exciting past 10 years.
Dr. Devlin, we love to hear that. I think that was our goal as we set out to improve access to care for patients with Viz. And I think it's amazing to hear from, real providers that are frontline, understanding what the impact of the technology can have. We understand that you've led a team on a recent study that's looked at that impact both on clinical outcomes for your patients, as well as the time to treatment impact that you've seen overall. Can you share some of your study findings from the Validate study, I believe?
Yes, thank you very much. Let me summarize Validate. Very straightforward. We have numerous studies previously that showed the benefit of Viz on stroke workflow. However, criticizing these studies, number one, the studies were small, typically single center studies, comprehensive centers, and looking at the improvement in times to treatment before and after Viz was implemented. But keep in mind, these are serial cohort studies with many years often between the pre-treatment group, pre-Viz, and the post-treatment group, and we're looking for a way to do simultaneous comparison of Viz versus non-Viz centers. And it can be very, very difficult to capture that data, number one. Number two, many of the studies that were done previously looked at a lot of metrics that VIS couldn't even directly control, such as the door in and door out time, or even stroke onset to the start of the intervention. And frankly, VIS does not control exactly what time an ambulance comes to an outside hospital to pick a patient up and transport them, or how quickly the interventionist can get in from his house at 2 o'clock in the morning to start a procedure. So what we wanted to do was we wanted to come up with a protocol that would allow us more scientifically rigorously to look at the benefit of this without some of these compounding variables, some of these confounding variables. And the way we figured the best way to do that is frankly to leverage telemedicine. So with telemedicine, we were able to look at a very large population of patients. In fact, across 17 states, 166 different facilities, 14,116 patients were analyzed, okay? About half of them were from VIS centers, and the other cohort was from centers that didn't have VIS. And the primary outcome measure we looked at was door-in time from the time that the patient arrived to the time that the decision was made by the stroke neurologist that it appeared that the patient had a large vessel occlusion, and the time that they actually first contacted the interventionist saying, we believe an intervention needs to be done. Yeah. And that is largely a VIS-driven metric. It would have been nice to have the actual CTA time to the time the interventionist was called, but across that many centers, we just don't have access to that data in our database. But since it was the same group of teleneurologists manning all of the stroke codes at both of these centers, and since all of the protocols at all of these centers is largely managed by telemedicine, we do really believe that these were very fair comparisons, that this was a very fair comparison between two matched cohorts. When we looked at the demographics of the two cohorts, they were matched very, very well. And when we looked at the primary endpoint in centers that had VIS versus centers that didn't have VIS, the primary outcome, which was highly statistically significant at the less than 0.001 level, was that there was a 39.5 minute faster time from patient arrival at the facility to the time that the LVO was recognized and the interventionist was first called. And in terms of time as brain, 39.5 minutes is a very, very large amount of time that is very, very clinically relevant. Now, one of the things that was very interesting is we then did a subgroup analysis, and we looked at, did it matter whether or not the patient first presented to the thrombectomy center or to the outside hospital? Some people surmise that we would only see a benefit of VIS when patients presented to an outside referral hospital, not a comprehensive center, but that's exactly what we did not find. In other words, what we found, again, at the less than 0.001 level, it did not matter whether or not the patient presented to a comprehensive center or a thrombectomy capable center or an outside referral hospital. In both cases, in the case of the non-thrombectomy center, it was a 33-minute difference. If they presented to the thrombectomy capable center, there was in fact a 34-minute faster time from patient arrival to the time that the interventionist was called and the intervention code was to be activated. So these are very dramatic results. Now, we took it a step farther. We then looked at, because we're looking at median times here, okay, we looked at the IQR range itself of all of the statistics. And we did statistics on the IQR range. And what we found was that there was statistically a much narrower range at the hospitals that had VIS. In other words, the dispersion around the median was much narrower at the VIS hospitals. And what does that mean? What it means is that the overall quality of the program, your outliers were much, much tighter at VIS. And what VIS did is not only did it shift the mean, but it overall improved the quality across all of the patients. And that's represented in a much tighter, statistically significant IQR range itself.
Yeah.
The last finding that I think is particularly relevant is we then looked at acceptance of patients for thrombectomy. And particularly in this post-COVID era, where outside hospitals, now that they have telemedicine, now that they have VIS-type technology, their goal is really to try to keep these patients at the outside hospital and not transfer the patients into a comprehensive center if in fact they don't need to come and if in fact they don't need a thrombectomy. What we found was in the centers that had VIS, there was a 10.79% absolute decrease in the acceptance of patients from outside of hospitals for thrombectomy, which translated into a 23% relative reduction in the chance of a patient being transferred. And what does that mean? And how did that happen? First of all, we think that's a very good thing. And the way this happened is now your interventionist can be on the phone with the outside hospital hearing about the patient, but he's now looking at the VIS app. He's able to manipulate the images and rotate three-dimensionally around any point and say, you know, I think that clot is a little bit too far out for us to get. We're not going to take that patient intervention, and that patient can stay at your facility. Keep in mind, families do not want to be transported with their loved ones, sometimes 60, 100 miles away, unless it's necessary. We do not want to incur the extra cost for the family, et cetera, et cetera. So we think, in summary, the VALIDATE study showed a tremendous win, win, win. A huge win for the patient, because the patient's care is greatly expedited. Number two, it's a huge win for the comprehensive center because now they're able to do an intervention on the patient faster, better outcome. And thirdly, it is a win for the referring hospital because they don't transfer patients unnecessarily that may not want to come anyway, and they have the benefit of keeping the patient at their facility. So a true win-win. I would encourage everybody to read VALIDATE, published in Frontiers. Just put in VALIDATE AI stroke and you'll pull it up. But what I was most excited about from this data is what you're going to hear about now with Dr. Mullins, where she did a deep dive on some of the economic implications of the VALIDATE results.
Yeah.
And with that, I will turn it back to you.
I love hearing all the wins there, Dr. Devlin. I think it's amazing to exactly what you said, the impact to patients, the operational efficiencies, all of those gains. Dr. Mullen, I know you've done a lot of research on this in terms of the use of AI and the impact on the economic benefit overall, in looking at the total cost of care. Would love to get your perspective on what you've been able to glean from this data and what that means to health systems, providers, patients, and caregivers across the board.
Thank you. So building off of that idea of these wins, as a health services researcher, I'm really interested in not in the quadruple aim, how much it gets better for the practitioners, the clinicians, the nurses, the surgeons, everyone, but also how it affects our patients. And finances, we need to have money to keep our doors open. And particularly in a day where most hospitals have very tight margins, it's important for us to think about efficient use of our resources. And so the project that we've done, and it's pre-publication, so we are in the review process right now. We took a look at stroke MSDRGs because the Medicare data is our best standardized data set that we can have access to, of course, across the United States. And we were looking at the different DRGs, and there are different DRGs for those stroke patients that have the thrombectomy, those that have thrombolytic medications, and then those that don't use either. And we started looking at how many patients were discharged, and this data lags by a year or two, as most Medicare data does. We started looking at how many of those discharges were happening for the non-surgical. So the cases that didn't have anything that was surgical that was at those comprehensive stroke centers. And most of those cases that were thrombolytics only, or that had neither thrombolytics, or they weren't candidates for thrombectomies, actually were still being seen at the main comprehensive centers. They're not seen in rural communities, but we know these strokes are happening in rural communities and in places where they have access to the telehealth and teleneurology. So they have access to these professionals. And so what I was looking at was, how many do we anticipate might be able to stay at these further out hospitals? And as Dr. Devlin brought up, there's wins. There's wins for the hospital, there's wins for the patients, there's wins for our clinicians. Everyone likes to be at home to get better. And this can keep some people at home or in their community where their friends and family have an easier time coming to see them and being part of that recovery journey. But what we noticed when we estimated out this effect, because of course, technology has some costs. We need to acknowledge that. Nothing comes for free. But when we looked at it, if you were able, a hospital was able to keep 10, 20 of these patients, it really could result, given these average payments across Medicare and across, and now I should caveat this, we understand that we used the average and not the rates, the specialized rates that some of these special hospitals that are critical access and others would also get in addition. But if they were able to keep 20 cases, they would actually come out in a net benefit after they had paid for the technology, and we come out, and we can't calculate really how much we would save, because some of these people would be taking air ambulances, ground ambulances into the comprehensive centers, but there is an enormous amount of savings there for the patient, the insurer, community, for government assistance type of programs like Medicaid, so state and federal, or Medicare. There's also a large, sizable, not insignificant savings to the patients. And then to the comprehensive stroke center that might traditionally, in the old model, have already received these patients. There is an impact, I want to acknowledge that, but at the same time, those surgeons are not all of a sudden surprised, here's someone at the door. The advantage with this technology is that they can do a warm reception, and they know exactly, as Dr. Devlin was talking about, they know exactly who's coming in and what their approach is going to be. And in the older model, they had the people who they were then starting to figure out, is this a surgical case? Is this someone who's a medication case? And so we're using projections. I suggest in the paper, Dr. Devlin is one of our authors as well, that hospitals use some of the resources that are available through the Centers for Medicare and Medicaid Services to estimate the savings that they could have from doing this kind of a partnership, using AI to figure out, who do we keep. The other benefit that I can't measure economically, but there is a real benefit, is the confidence that these remote clinicians feel in having expertise on the phone, essentially looking at the same patient at the same time.
Yeah.
So if you're someone who doesn't see dozens of strokes a week, like the clinicians in the comprehensive stroke program, these remote physicians have the confidence of you've got an expert and everyone's huddling at the same time with the same data on the same patient and making the best choice for recommendations for treatment and for place that treatment should happen.
Yeah.
So it saves us money. It helps with revenue cycles in our more distant hospitals. And it certainly helps with comprehensive programs, helps them be more efficient. But also a lot of those facilities face tremendous pressures in their emergency departments and other places in their hospital where there are bottlenecks. So this takes the patients who are best seen there and directs them into a faster treatment as they found.
Yeah. Dr. Mullen, it's so interesting to hear of those findings. You know, we always hear AI can have such a significant impact on patient outcomes and what that means, but to be able to actually quantify it and to understand, you know, what does that mean from an economic perspective is pretty significant. And it's amazing work that you've done to be able to pull that together. And we really appreciate you sharing your early insights into that data. And we look forward to seeing that publication come out, because I think it's an open question that many across the board have had. And I think it's great that you've been able to help us as we think through those pieces on, does this make sense for our health systems as they look at investments? And thank you again, Dr. Devlin, for sharing your study as well. I think there's always more research to be had in both these areas, but amazing to hear that there's significant impact and opportunity that has been already shed with the stories that you've been able to tell with the publications and some of the data that you've brought to light today.
I think now, if I may just close by saying, industry has really worked terribly hard to give us the tools which you now have with AI. We now have the ability to do it. Financially, there's no obstacles because this is a win from a business model standpoint for both hospitals. But now it is really time that we take the next step. And the next step is getting this technology implemented, having hospital administrators agree to adopt it, and then the critical step around connectivity. We have to wire the country together with AI technology so that all of our doctors, when they get called from an outside hospital, have the tools in their hands to be able to look very quickly. But without that connectivity of these systems, implementation and connectivity of the systems, we cannot begin to leverage and harness the full potential that's in the systems that you've given us. And that's up to the hospital administrators. And we do hope that by providing a data-driven approach and a financial support and the financial tools to analyze the benefit, that now physicians that know and appreciate the clinical need, that we can bring and we can execute on this vision and this next goal that we have in mind. Thank you.
Absolutely. Dr. Devlin, let's do this together. I think this is a win to get the right patients to the right level of care and improve outcomes and benefit across the board. So thank you again for those wonderful insights, Dr. Devlin and Dr. Mullen. Wonderful to have you on this podcast with us today.